morning. I would like to thank the AIOS for this opportunity, and I'll be talking about the basically the lymphoid-associated ocular surface lesions, and these mainly include basically the lymphoid hyperplasia, which may be a typical or atypical lymphoid hyperplasia or a lymphoma, and all of these are big mimics, and it's very difficult to sometimes distinguish one from the other. Important to understand the basic anatomy of the conjunctiva. We know the layers of the conjunctiva. It's also important to understand that the conjunctiva has the conjunctiva associated lymphoid tissue in the substantia propria, and this can be a source of lymphoproliferative disease in the cornea. Along with this, we also have the eye associated lymphoid tissue. Now, the tumors of the conjunctiva, they have been classified according to the layer from which they are arising. So, we have the tumors arising from the surface epithelium, tumors of the melanocytic origin and adnexal structures, and then we come to the tumors of lymphocytic or hemopoietic origin and the tumors of soft tissue origin. For this talk, the focus is on the reactive lymphoid hyperplasia or the atypical lymphoid hyperplasia, and also lymphoma and other entities like leukemia or plasmacytoma, which might cause. So if you take a good look at these photographs, it's very difficult for us to reach a diagnosis what it is. So for this, it's important for us to keep certain points in mind. These are specific regarding lymphoid tumors, but may be applicable to other masses as well. Usually these patients are asymptomatic. These masses are sharply demarcated, and if you see the salmon pink color, they say that on the slit lamp, due to the intense light, it may not be clear that salmon pink color. So the best thing is to examine the patient in daylight. They are insidious in nature, they are non-tender, non-ulcerated, and apparently they will lack the typical feeder vessels. And other features of that it's not really malignant would be a surface nodularity or follicularity, as is seen in this case, kind of multifocality and a minimum elevation of the lesions. So the photographs I was showing to you, number one was an amelanotic melanoma, the second was a conjunctival lymphoma, and third a benign reactive hyperplasia and a papilloma. Now, I can't overemphasize the role of the anti-segment OCT. It's such an easy investigation. It's an expensive tool to get, but it's very relevant to the corneal surgeons, and none situation more common, more applicable than this. Paris has shown some images of the OSSN. But in conjunctival lymphoma is a fairly typical kind of an appearance, that you will have a hyporeflective, homogeneous kind of a mass with dot-like reflectivity, and also there's a superior and inferior hyperreflective band which is seen in these patients. This may also be present in benign reactive lymphoid hyperplasia, but classically in some cases, but it's a more disorganized kind of a structure which is there in benign reactive lymphoid hyperplasia. Conjunctival amyloidosis is something which may mimic these lesions, but again this has a heterogeneous structures with irregular borders. So this is a classical appearance of a patient with, again, on one of those hyporeflective kind of a lesion. You can also see the subepithelial hyperreflective band in this patient. And this, on the other hand, if you see this is a patient of benign reactive lymphoid hyperplasia, you can see these hyperreflective areas actually corresponding to aggregations of the lymphocytes. This example just shows that it may be possible for benign reactive lymphoid hyperplasia to mimic the lymphoma. So, and again the disorganized kind of an anti-segment OCT with some kind of a stippled kind of an lesions which we see in amyloidosis. Now, if you look at ocular adnexal lymphomas, 20 to 30% of them will arise in the conjunctiva, and they are associated with systemic lymphoma. And usually the age group is more than 50 years. So when you have the age group of the patient is important, but it has been reported as young as 12 years of age. If you look at the epidemiology and the location, so 90% of these lymphomas, they arise from the B lymphocytes. And the term ocular adnexal lymphomas is commonly used, and they are unilateral in majority of cases, but they may be bilateral as well. So the etiology is very interesting in these patients. chronic inflammation can trigger the formation of these kind of lesions. And also the immune dysfunction disorders, Sjogren's syndrome, rheumatoid arthritis, SLE, and most interesting is infective organisms like Chlamydia psittaci and Chlamydia pneumoniae and hepatitis and Helicobacter pylori, herpes simplex virus and adenovirus. They've all been linked with the presence of these kind of lesions in the eye. Also some genetic factors like trisomy 3 and 18 predispose these patients. If you look at classification in these patients, so most of these, the most high grade ones, I told you that the major source is the B cell, non-Hodgkin lymphoma. So the most common out of them is the extranodal marginal zone lymphoma. This is important because once we take the biopsy and the report which comes, we should be able to prognosticate for the patient. Follicular lymphoma is also fairly common in these patients. So this diagram just shows actually that this marginal zone is what is responsible for the extranodal mantle cell. So how to stage it, and arbor staging is not very applicable here since it's a localized disease. So we are going in for a TNM staging. So so an important question is when to take a biopsy. Some of these lesions look so innocuous, and I really don't have a guideline for when to take a biopsy in these patients or not. But we should be probably more aggressive for caruncular or fornical lesions, which have more chances of being malignant or turning malignant later on. This patient had bilateral lesions and was very worried about them. So we did do an anterior segment OCT in this patient, which did show this very classical kind of a subepithelial kind of a band and with the kind of homogeneous kind of an appearance, not the classical like benign reactive lymphoid hyperplasia, but we did decide to go ahead and take a biopsy. But the staining characteristics showed that nothing more was required, and this was a patient of benign reactive lymphoid hyperplasia. This is a patient of Chinson's, and which I borrowed for this class, and very interesting patient, 55-year-old lady, and you can see the salmon pink color, classical color of this this lesion, the location of this lesion. You can't see a classical typical feeder vessel in this case. And once we did keep this differential diagnosis in mind of a lymphoma. Of course, an amyloidotic melanoma should be kept in mind, or an OSSN, or maybe one of these lesions. So if you look at the anterior segment OCT in these patients, you can see this presence of these lymphoid follicles and hyperreflective homogeneous subepithelial mass and hyperreflective normal epithelium. Immediately your antennas should be up that you want to be more aggressive while treating this kind of a patient. If you want to really check for some adhesion to the underlying structure, you can do the UBM and to see the if the angle is involved or the sclera is involved. Mobility tests should be done in these patients. Very important to have a good pathology team with you, because the pattern of staining that you will get ultimately is the pattern which will get you through this grid. And once you put the plus and the minuses together, you'll be able to reach the diagnosis as to what the patient is suffering from. The recommended investigations, we have to tailor them, but we do have to sometimes investigate in big detail, like radiograph, CT orbit, and endoscopy, blood counts, sedimentation rate, rheumatoid factor, serum protein immunoelectrophoresis, and maybe sometimes in biopsy, bone marrow biopsy, ANA, bone scan, liver spleen scan, and PET scan. In this case, if I go